Hello, my name is Pearson, and I'm a physiotherapist and a yoga therapist and a clinical assistant professor at the University of British Columbia. And it's a pleasure to be able to offer you this presentation as part of the Alberta Pain Education Collaborative. So we're going to talk about pain education, and specifically talking about helping people to reconceptualize pain, or to see pain as something more complex than just a tissue health meter. And so what I want to do as we go through this is sort of address the issues that a lot of us have, is that sometimes it's pretty challenging to provide pain education. So I guess we want to start with the idea of recognizing that full reconceptualization of pain is pretty difficult in a lot of people, and it's not always necessary. I'd also like to give you some different approaches that you might take in terms of providing effective pain education, and talk about some strategies and scripts you could use. So before we get to that bubble diagram that I was just about to show you there, we start with embedded views of pain. We, as in everybody in the world, we have beliefs about pain, we have thoughts about pain. And when we're educating people about pain, we're not educating to a blank slate. We are attempting to get people to think about pain in different ways. And so I just want to give you a quick example for us. So we all have embedded views. So you probably have views about how much do opioids change pain. And then if you compared that to, well, if opioids change pain that much, how much do you think multidisciplinary pain management changes pain, or yoga changes pain, or hypnosis, or relaxation, or acupuncture? You probably have some ideas of where those are. And a few years ago, some researchers who were looking at pharmacological treatments versus non-pharmacological treatments, and they're also looking at brain changes in the study, or in the paper that they wrote. Here's the evidence that they have for effect size. So opioids changing pain, a moderate effect at about 0.6 with Cohen's effect size. And you can see a whole bunch of the non-pharmacological treatments are getting similar kinds of changes in pain. And for some of you listening to this and watching this, this may seem a little unlikely. And so you may have the experience of, well, he's telling me that this is what is all based on research, but I'm still sort of skeptical about it. And so that would be, is that you haven't fully reconceptualized this idea. This idea makes sense, but you're still sort of wondering, is it really true? And we often run into that with the people that we work with. Whereas we just sort of have this idea, as we'll educate people and they'll understand it and they'll be able to move on. Of course, we know it never works, or rarely works like that. The embedded beliefs that people have are mostly these. There are other ones, but the idea that pain equals tissue damage, that if the pain is persisting, there must still be damage happening there. The next one is sort of an implicit one. People usually don't say to us, well, pain's immutable. What we usually have is people having this sense that, this sort of internal sense of pain is not something that is I can change, or something that can change without fixing the tissue. Which sort of leads into the last one, is that the idea that pain care, pain management, is all about learning how to cope with it. There's no other option besides taking medication, surgery, or coping with it. There's no way we can change pain itself. Whereas when we ask people to reconceptualize pain, of course, we want people to make sure they understand that the pain is real. But we also want to know, or want the person to understand, that pain is something that they have some efficacy around. They have some influence over it. We also want people to know that they can recover more ease of movement, even when the tissue isn't getting better. And of course, as I mentioned, the idea that we want people to know that pain is not an accurate indication of what's happening in their tissue, or tissue health, or tissue damage. In other words, it's not a accurate tissue health meter. So because pain reconceptualization, or reconceptualized pain is difficult, we might start with different goals. So you might start with the goal of, well, I want to get this person to reconceptualize pain. But maybe what you need to do is start with the goal of saying, I'm going to provide this education in a way that will build therapeutic alliance, because we know that that's a really important part of our clinical work. Or maybe what you do is you say, well, if getting people to fully reconceptualize pain is difficult, maybe the first step is to get people to cultivate curiosity, or your job is to help the person cultivate curiosity, to be curious about what they think about pain, or to say it in a different way is maybe your goal is to get the person to think about what they think about pain, which I think is a really valid place to start, rather than starting with the idea of getting the person to do this full shift. Start with these other goals, because for a lot of people, this is a better way to start. And what's fascinating is that you'll find that some patients almost have this this sensor of why is this person trying so hard to change my beliefs? And it sounds like when that happens, the person is more likely to not reconceptualize pain. And one of the ways we can do this around pain education is talk about how weird pain is. You know, like phantom pain, that's a pretty weird pain. People having big injuries and not having any pain at all for a while, that's sort of weird. So we can sort of talk about pain in this way that gets people to start to be more curious about it. Because everyone's heard of stories that don't actually match with pain equals damage, right? Or that and people have heard stories about people with fairly catastrophic injuries who actually are back to life and not really having a lot of pain at all. So we can provide pain education through giving people information, but it's more successful when we actually use experiences and stories. And those of you who have read the work of Lorimer Moseley and David Butler, you see people who are really wonderful storytellers and actually use story and metaphor to help people understand pain rather than just giving them the facts. And it's important, I think, for us to recognize is that if you're doing an explained pain or a pain neuroscience education, the reason you're telling people about neurons and neurotransmitters and neuroplasticity is you're using that as an agent of education. It's not that important for the person to understand neurons and neurotransmitters and neuroplasticity. What you're using is that as a pathway to be able to get people to the understanding that pain is different from what they thought. So we can provide people with experiences and stories. And often when we do this, the information is inconsistent with the person's belief or understanding about pain, or their beliefs or understanding about pain care. And so often these stories are stories of people who've been able to recover function, even though their body wasn't normal, or they can be stories of people learning to be able to change the pain without fixing the tissue. We can also provide pain education through a more contemplative practice. And hopefully you understand that the first approach is a pretty cognitive approach. And so are contemplative practices like mindfulness and meditation and breathing and even things like mantra or affirmations. They're more of a cognitive approach. But again, the idea of these practices is to give people experiences that, once again, are inconsistent with their worldview or their beliefs or understanding about pain or pain care. So as an example, it's possible that you've got somebody in front of you who's got neck pain, and you take them through a mindfulness technique. And at the end of the mindfulness technique, the person can actually move their neck with more ease. And of course, if the person can move their neck with more ease, they've just had an experience that's inconsistent with their belief that the only way to be able to move better is to fix my neck. And so, of course, I hope you understand that if this is the person's worldview, is that, well, that's not possible. What can actually happen is the person takes this new experience and just parks it outside their worldview. But if you continue to give that person repeated experiences of this, what actually happens is people will start to integrate that new experience into their worldview without creating a whole lot of, or not as much resistance or cognitive dissonance. We can also provide people with more education through movement. I think it's a really important thing to consider is that a lot of us learn best through doing better than sitting down and reading or listening. And so we have some good research around yoga. We have a little less, but still good research around the effectiveness of Tai Chi for people with chronic pain, and less around Feldenkrais and Qigong. But all these are mindful movement practices where the person's moving usually in novel ways, but also the person's focusing on their breath and their body while they're doing it. So being mindful of self while they're moving. And there's something about that changes pain. But one of the ways that, once again, that we can think about it is the mindful movement is giving the person the experience that they actually can move without being so provocative to the pain, or that they can move and at the end of it, they have less pain or better range of motion. which of course, again, comes back to that's not consistent with what most people believe about pain. That is not consistent with if there's pain, there's damage, and I can't change the damage, and therefore I can't change my function. So we can also educate people through social persuasion. And I wish I could tell you there's a bunch of research around this, but I haven't seen any. But social persuasion really it's using the stories of other people who often are present. And we know that this is one of the reasons why peer support groups can work. But it's the thing to consider is that if early on when I was teaching group education on this, if there was somebody in the room sort of sitting back, crossing their arms and maybe their legs and looking at me sort of sideways, what I would start to do is I'd try to talk to the people in between us. And if I could get the people in between us to start to nod their head and interact with me in a positive way, sometimes it got the person who is the skeptic to start to wonder, well, maybe what I had to say was of some benefit or could be so helpful to them in some way. And so, like I say, we don't have a whole lot of research around this, but I think it's something that's really, really important, is that we can use social persuasion. And part of the reason I bring this up is that you all know that we believe that pain care needs to be individualized, and this totally makes sense. But in making pain care individualized, one of the things that we've actually done is we have made it lonely work, so to speak. And that we've missed the idea is that, yes, we can make things individualized, but there's power in having people do things together. And one way that you can actually get social persuasion is by getting people to do contemplative practices or education or movement practice together as a group. And through the group, you can actually use the people who are already starting to reconceptualize pain and get them and their discussions to help the other people in the room start to do it as well. If you're a skeptic and you're hearing a whole lot of other people saying, maybe this idea you're skeptic about may be of some value, it could help you to shift. And we haven't really paid a lot of attention to that in most of the pain management we've been doing. So I want to give you a couple quick examples of this. So this is something that I often use with patients. And so I'll put this up and I'll say, so I'm guessing when you look at this, it looks like a three-dimensional thingamabob, right? And so it looks like a cube or a square or a block or something like that. And say, so when you first looked at this, what actually happened was those are actually a bunch of black lines on a white background, right? So those are black lines on a white background, and that information came through light, excited nerves in your eyes. The information relayed back to your brain, and somewhere in your brain came up with this three-dimensional thingamabob for you. I'm sure those of you looking at it, you didn't look at it and say, oh, it's a bunch of black lines on a white background. I think I'll make a box into it, right? It happened automatically. And now when you first looked at it, you might have seen it more like this with the top right side poking out at you, or you might have seen it like this with the bottom right side sort of poking more out towards you. It doesn't matter which way you saw it. And just there's a red dot on this. And the idea of the red dot on this is to maybe help some people who have a hard time changing it. So right now, what I want you to do is see, can you change it so that you can see it this way, and then you can change it and see it that way, even though all the lines are back there now. And sometimes the red dot, you sort of push it into the back bottom corner, or you pull it into the front bottom corner, and that can shift it for you. But the idea here is that if you can change how you see this box or this cube or these black lines, that means that you can change how you perceive visual input. And of course, if you can change how you or your brain decides to see that or perceive that visual input, the question is, can you change how your brain perceives danger input? Which for most people with chronic pain, they sort of have this sort of nodding their head, once again, skeptical face going on, because the person's having two things going on. One, thinking of, well, it can't be that easy. And the second thing is, no one ever told me that I have any influence over this. And so this is the kind of an experience that you can give people through interactive education to get people to understand, is that pain may be something to get the person to be curious about. Well, maybe pain is something that I do have some influence over, because I can influence how I see things. Maybe I could influence how I feel sensations from my body as well. And it doesn't matter if the person fully buys it, just you want the person to start to be curious about, well, I wonder if that is true. And of course, one of the things we tell people around this is that it's way easier to change how your brain perceives this box than it is to change how your brain perceives danger signals. And we think that's because pain is such a higher priority. With pain education, we can also use other examples like brain freeze. And so we can sort of put this picture up and say to the person, so is the intensity of pain in brain freeze an accurate indication of how badly your body's damaged? Which people say no, and you say, well, is the location of pain in brain freeze an accurate indication of where the problem is? Which once again gets you a no. And then you ask them this question: is brain freeze a good protection mechanism? And most people will say no. And part of the reason they say no is because you just got them to say no twice in a row before. But the other reason is because the person's thinking that the purpose of the pain is to tell them where the problem is, what the problem is, and how bad the problem is. But then we go back and we say to the person, well, protection mechanisms don't quite work like that. The purpose of a protection mechanism is to get you to stop or change your behavior. So if that's the purpose of a protection mechanism, is brain freeze a good protection mechanism? So people can start to see that, so brain freeze is a protection mechanism, while pain is a protection mechanism too, and to start to understand pain in this new way, right? Again, you're not asking the person to fully reconceptualize here, you're just getting the person an experience that's different, that gets the person to start to think about what they think about pain. In terms of some educational scripts that we can provide with people, we can use simple things like this: is to, say I could provide acupuncture, or I'm a manual therapist, so I'm doing manual therapy to a person. What I might say to the person is, I'm going to do this because I want you to be able to move with more ease. Which often the person might sort of look at you a little funny because they were thinking you're going to do it to give them less pain. But if you can think about something like acupuncture or manual therapy, if I can do that to you and at the end of it you can move with more ease, well, you've just actually learned something that's part of pain education. You've learned that you can actually change your ease of movement without really changing the tissue. Now, somebody might say, well, manual therapy, maybe you did change the tissue, but if it's my neck and you're putting acupuncture needles in my hand or my shoulder, now my neck, and I can move with more ease, most people are going to realize I changed my neck movement without changing the tissue. And so that's something new that a person may not have experienced before. Other times we might say to the person, the reason I'm doing this is because I want you to experience that your pain actually is changeable. Right? I'm going to do a dry needling technique or IMS, or I'm going to do manual therapy, or I'm going to do some other technique because I want you to experience that the pain changes, which is really important for a lot of people, to experience that pain is something that is changeable. And then, of course, the last one is I want you to know that you can influence your pain. If I gave you a slow breathing technique or a mindfulness technique, or took you through an imagery technique, and at the end of it, your pain was less, I would say something like, that's fantastic, your pain changed, because I really want to highlight to you that pain is changeable. But then, of course, if you did the technique and the pain changed, I'd really want to highlight this idea is, that's amazing, you changed your pain. I would also, by the way, go one step further with that person and say, imagine if you did that technique this many minutes a day for these many days a week and this many weeks. So imagine if you did it this many times a day for the next 4 to 6 weeks, how much better you'd be at changing the pain, which is another piece of the education bit, right? Is that not only do we want people to understand that pain is changeable, but we want people to understand that a lot of the pain self-care techniques are actually skills that if you practice them, you'll get better and better at over time. So this is another script we could use, or example we could use. So this guy's job is building birdhouses, and he's running late, and his wife is calling him to try to get him to come home, and he's really anxious and agitated, but he's got to get this job done, and he hits his thumb. And of course, the question is, so if he did it at this point, would he have more pain than normal or less pain than normal when he's so agitated by all this stuff? And it doesn't really matter whether people think it's more or less. What you can do is get people to realize is that you know something about pain you haven't really thought about. You know that how much pain he has to do with him hitting his thumb, and how the systems of him, the systems, say, of his body and his brain, are actually dealing with the fact that he hit his thumb. And most people can sort of get that, right? Is the pain has to do with what's happened in his body and how the systems are dealing with that. And so this sort of leads us to this other piece of pain education that we want people to understand, is that Our job is to help you with your body and with how the systems are dealing with what's happening with your body, which really opens the door to, well, what are those other systems about? And we can sort of open the person's view to that pain care is not just about fixing the body, and changing pain is not just reliant on fixing the body, that there's other things that we can do around it. This is one I borrowed from Lorimer Moseley. The idea that our body can tolerate, in the little graph you see there, our body can tolerate a certain amount of force, and then if you put more on, you'll get tissue damage. When people have a sensitized nervous system or are persisting pain, the alarm is actually moved from right at the edge of where tolerance and damage is going on down further. Now, there's always a buffer between where pain, sorry, if you're paying attention, there's always a buffer between when pain starts to increase and when damage would happen. When you have a sensitized nervous system or persistent pain, the alarm is coming on sooner, so you actually have a bigger buffer. And this is another thing we want people to understand, is that the pain you feel, even when there's a bigger buffer, when the pain increases, it still feels like you're going to damage yourself there. Like, how the pain feels doesn't tell you that you're at the edge of the buffer versus the edge of damage. We just need to get people to understand this. And part of the way we educate around this is to give this, often give people this kind of a model, but then give people the experience of, well, what happened if you went up and you nudged the pain just a little bit and then moved away, nudged it a bit and moved away, and to show people that they can actually do that without provoking the pain or without staying worse. And we can use the same sort of idea that we take from the concussion rehab world. I'm sure those of you who work in concussion rehab know that more recently, what we've started to do is ask people within 3, 4, 5 days after concussion to start to purposefully provoke the symptoms of a concussion. And sometimes this is another thing that we can tell people is that, we do this with people with concussion. Let's try it with you. So I want you to do that movement that provokes the pain, but just so you just feel the pain being provoked, or you just feel your protective mechanism being provoked. And then what we want you to do is recover. And once you've recovered, we want you to go back and do it again. And which I know when you do this with people, they're often looking at you, yeah, this sounds really wacky. But the idea is we do it with people who have concussion, and we're asking them to provoke dizziness and nausea and eye symptoms and headaches, and people succeed with doing it there. But somehow we seem to have a hesitancy to use this kind of a process to educate people about pain in a way that would teach them is that, hey, you know what? See, what this teaches people is that you have, again, some efficacy around this. There's something that you can do to start to change this. Now, I know that we don't really have time for questions, we don't have a process for questions here. I'm sure that has brought up some questions for you. If anyone has any really big ones and you really want to send me an email, go ahead and send it to neil@paincareu.com. Thank you again to everyone who set up this conference and for inviting me here. And I hope you all have gained some useful ideas from this presentation.